Good day. My name is John Poyaoan, and I'm here to present my project entitled Early Mobilization and Length of Stay in the Medical Intensive Care Unit. The member of the committee that helped me complete this project is my chair, Dr. Gordon West from Maryville University, and my community member, Dr. Amirawati Abdullah, which is a medical doctor in the project site, and she has helped me tremendously in coordinating all the aspects of this project towards my stakeholders. To start off, for the background of my project, there is an observed prolonged length of stay or LOS in the chosen medical intensive care unit or MICU. The physical therapy visits for the MICU patients has been observed to be non-consistent, and usually it occurs towards the end of the MICU stay, wherein the patients are not anymore intubated or not anymore under life-saving interventions, and they are actually able to talk and walk with assistance. And finally, there has been a bed rest culture in the MICU wherein the staff will keep their patients in the bed for as long as they can, and there is minimal to no mobilization that has been observed. The MICU implements this ICU Liberation Bundle by the Society of Critical Care Medicine. However, because of the decreased observed implementation of physical therapy in there, the E element, early mobility and exercises will need more attention. Now, early mobilization or EM has been shown to improve the cardiopulmonary status. It can also decrease the use of mechanical ventilation. It can improve the muscle strength, the functional status. It can also reduce the readmission rates and thereby decreasing the healthcare costs. Overall, it was found to reduce the length of stay of patients. Now, I created here a framework of my aims for this project where early mobilization was implemented to the MICU patients, which can lead to decreased length of stay. Now, specifically, to answer the following pilot question: does an enhanced EM program decrease the LOS of MICU patients compared to a regular physical therapy program after 3 months of implementation? I will now present the themes of my review of literature. First is the early mobilization methods. Now, you can notice here, these are all arranged by progressive order because these studies here implemented early mobilization in a progressive manner, from in-bed range of motion, moving to the edge of the bed, standing, transferring to a chair, and then ambulation. While early mobilization has been the intervention received by the experimental group of those studies, standard care is the one that has been received by the comparison group. Now, among the literature study, there is an unclear definition about standard care, and they vary among study settings. And the common denominator is that standard care referred to an unstructured provision of physical therapy in the ICU. Next theme of review of literature is that EM is implemented in a multidisciplinary approach. Now, this team composes of doctors, nurses, pharmacists, nutritionists, respiratory therapists, the nurses, and the physical therapists, and the occupational therapists as well. Now, the next theme is the safety criteria for early mobilization, where the patients are screened before implementation of EM. Now, the common denominator is that the safety criteria all composed of the following categories. Patients were screened about their hemodynamic status, respiratory status, neurologic and psychiatric status, and the number of contractions. All of these were used to evaluate if the patients are deemed safe to undergo a higher level of EM. As to the effects of the length of stay, early mobilization has been found to have benefit of decreasing the length of stay in the intensive care unit. However, other studies have not found that this is consistent. The other benefits of early mobilization included improved cardiopulmonary status, improved muscle strength and functioning, and overall survival. It has also been found to decrease the rate of mechanical ventilation use and also the decreased delirium and decreased use of sedation medications. The last theme is the barrister implementation of early mobilization, which is subdivided into two categories. First is patient-related and staff-related. For the patient-related factors, it only included the increasing severity of illness of the patients, which diminished their abilities to perform at a higher level of early mobilization. And then the next factor is the staff-related concerns, which includes the staffing constraints or inadequate staff. There's also been an observed lack of direction and leadership, and then also a lack of motivation from the staff. This project has operated on the following theoretical frameworks. First is Ross adaptation model, wherein early mobilization helps the MICU patients adapt during their illness towards better health. Now, early mobilization is the adaptation that helps the MICU patients to attain better health outcomes. Next is Dorothea Orem's self-care deficit theories, wherein early mobilization is a way of providing mobility to the MICU patients when they are unable to do so. Now we know that ICU patients with the severity of illness and the amount of contractions they have, they will need assistance to be mobilized while they're in the ICU. So early mobilization is a way of fulfilling that need. Finally, early mobilization, this project operates on the Society of Critical Care Medicine's ICU Liberation Bundle, where it completes the E element or early mobilization and exercise to make the care of the MICU patients a more holistic approach. Now, my project followed the quality improvement model. It is a quality improvement project where retrospective chart review was done to review the length of stay of medical ICU patients before and after implementation of EM. Now, for the interventions, I summarize it here. The comparison group or the pre-test group received the standard care, which is an unstructured, inconsistent pattern of early mobilization provided only by PTs and OTs. Then next is the intervention group or the post-test group, which received the new EM process. The intervention of my project is the early mobilization or EM. It has evidences of improved cardiopulmonary status, muscle strength, functionality, and overall survival. It is implemented within the 48 hours of MICU admission. It is performed by PTs, OTs, and nurses. And during multidisciplinary rounds daily, all patients are screened for the risk of adverse events using the criteria by Hudson in 2014, which is done to determine the level of physical mobility in bed or out of bed. Now, this is the safety criteria that has been applied among each patient. It had green, yellow, and red symbols, which pertains to low risk, potential risk, and significant risk of adverse events during mobilization. And it has been divided between in-bed and out-of-bed activities or exercises. And these criteria has been divided into different categories. There's respiratory considerations, there's cardiovascular considerations, neurologic or psychiatric, devices, and other considerations. Now presented here is the door card, which is printed and posted outside the door of a patient's room in the ICU. Now, early mobilization is a progressive mobilization based on the Johns Hopkins highest level of mobility, which is seen here in this chart. Now, it has mobility progression from laying in bed up until walking 250 feet or more, depending on the patient's tolerance. Now, we can see here that the current JHHLM score of a patient is written outside in the door card outside the room, and then the goal is set by the team. Now, on the left-hand side is the safety criteria for mobilization. Again, green for low risk, yellow for potential risk, and red for significant risk of adverse events. So after the team's evaluation, we put a tick mark here, which means that the patients are given the chance to have early mobilization done for that day. The participants of my project included the patients admitted in the MICU from August 1, 2022 to January 31, 2023, regardless of their diagnosis. And the following inclusion criteria has been followed. They must be 18 years old and above. They must be admitted under the MICU intensivist service. And lastly, they must be screened with the safety criteria by Hudson et al. 2014. And they will be excluded if they are readmitted in the MICU during the same hospitalization, if they have written bed rest orders, if the patient whose care is transferred to a non-MICU intensivist service or non-MICU hospitalist service, and finally, the counting of the length of stay will stop once the patient had comfort measures orders only. Before the retrospective data collection ensued, I had to seek clearance from Vanderbilt University Institutional Review Board, or IRB, the project site's IRB, and the project site's legal team. This is all to make sure that I'm safe and good to go in gathering the data. Now for the comparison group or the pretest group, the following observation months has been used. Month 1 is August 2022, month 2 is September 2022, and month 3 is October 2022. And then for the intervention group, this is the post-test group. The following are the observation months. Number 1 is November 2022. Observation month 2 is December 2022. And observation month 3 is January 2023. Now, this has been done to make sure that there's proper labeling and proper references to the succeeding slides, as the number of patients admitted during these months and their average length of stay will be presented. I utilized the Mann-Whitney-U test to determine any significant changes after my project has been done. It is a non-parametric test for highly variable data, which has been used to determine any changes before and after an intervention has been implemented. Now, my data has indeed been observed as highly variable as follows. For my comparison group, the observed length of stay is 0 to 21.2 days range for 809 patients, with a standard deviation of 2.85 days. And for the intervention group, the observed length of stay range is 0 to 24.9 days for 749 patients, with a standard deviation of 2.69 days. Now, according to Standard Calc 2024, any data is highly variable when their standard deviation is above 2, meaning that my use of Mann-Whitney-U test is justified. Mann-Whitney-U test, instead of using the arithmetic mean, actually uses the sum of ranks and then the mean rank to compare the data. What SPSS has done is that it arranged my data from the highest to lowest and then assigned them ranks and then totaled these ranks and got its average. So we can see here in my table that the comparison group had a mean rank of 746.93 and the intervention group had a mean rank of 810.52. Now we can already see that the intervention group had a slightly higher mean rank compared to the comparison group. Now, is this this is actually suggesting that there is probably a more prolonged length of stay among the intervention group compared to the comparison group. However, the question is this significant or not? Now, the Mann-Whitney-U test statistic that has been computed indicated that this prolonged average length of stay during the EM implementation was statistically significant. The question is, what is the effect size of this statistic? The computed Z of the Mann-Whitney-U test is negative 2.796, and then the computed Cohen's D is negative 0.14, meaning that the comparison group mean rank was 14% of a standard deviation lower than the intervention group mean rank. And the eta squared is computed as 0.005, meaning that the difference between the comparison and intervention group accounted for only 0.5% of the rank variance. Now, for the effect sizes of 0 to 0.19, this statistic has a trivial effect according to Cohen in 1992. Now, meaning the computed Cohen's D and the eta squared falls between the trivial effect size according to Cohen in 1992, meaning that we can disregard the statistic computed using the Mann-Whitney-U test and base the result of the project among the data trends that has been observed. Now, this is the figure that represents the data trend for my comparison group or the pretest group. We can see here that there has been a non-recognizable pattern between the number of patients admitted per observation month and the average length of stay. For example, for observation month 1, it is the highest number of patients. However, it had the least number of length of stay or least duration of length of stay. And then observation months 2 and 3 has relatively the same number of admissions per month. However, they had a slightly higher and a slightly lower average length of stay, which is highly variable. This table, this data, and the comparison group is highly variable. Then this figure represents the data that I have seen after implementation of EM among the intervention group. So we can see here the number of patients has been increasing during the observation months as it progresses. And on the other hand, the length of stay has been seen to have a decreasing pattern, which means to say we can already see there is an inverse pattern between the monthly number of patients and the average length of stay. With the increasing number of patients admissions, there has been a decrease in the average length of stay. So think about this. With the increasing or the higher number of length of stay, higher duration of length of stay, we can see that the admissions has been decreased. And as the average length of stay has been reduced, more and more patients has been able to be discharged out of the MICU, and then more and more patients has been admitted, leading to an increased number of patients admissions during month 3. We can actually see it here. As long as the average length of stay duration decreases, we can see an increasing number of patients being admitted in the MICU, meaning more and more rooms are utilized for new medical intensive care unit patients. Therefore, my project's findings suggest that there has been a higher number of patients admissions per month with a decreasing average length of stay in the MICU after the EM has been implemented. This suggests that there has been a benefit in implementing EM among the MICU patients, and the benefit is a decreased length of stay. For the limitations of my project, I found it very difficult to justify the decreased length of stay, as no other data has been recorded in my project. I could have used the duration of mechanical ventilation, the frequency of delirium, the diagnosis, the top diagnosis in the MICU during my study period. I could have also used the presence of delirium, the use of sedation medications, the amount of physical therapy provided, the frequency of physical therapy session that has been done. I could have also used the highest level of mobility attained by each MICU patients. However, I chose not to include that in my project because it will become much more complicated to be just a DNP project. It shall involve like a multidisciplinary study, which will involve more people other than me, more rigorous research methodology, and more funds to actually conduct it. Now, other limitations included that we have observed a higher acuity of patients. Again, it is observed, it is not recorded. In higher acuity of patients, these are patients that were never or not able to actually proceed to a higher level of EM because of their degree of illness. And then finally, the physical therapists and the occupational therapists are not included in the multidisciplinary rounds. As much as we want to include them, their staffing is still very limited to be part of this project. But the PTs and OTs contribution to this project in the implementation has been really detrimental for its success. The decreased length of stay after implementation of EM has been consistent with other studies. And then the results of this project follow the trend of these studies actually. And then finally, although our clinical indicators were not explored in this project, a decreasing patient's length of stay in the ICU reflects a better health outcome. Then other discussion will be that I felt that as a nurse practitioner, an aspiring nurse practitioner, my leadership skills has been a test. It has been a very important role. I recognize the importance of a nurse practitioner as a leader in leading this multidisciplinary team and a group of patients, a group of nurses, into helping these patients achieve a better health outcome through the use of mobility. As for my project implementation, first is I recommended the continued implementation of EM in the MICU because of the observed benefit of decreasing the length of stay. Next is I would recommend the adaptation of the EM process into the other ICUs of the project site, although this might be difficult because the other ICUs follows a pattern of their own specialty systems. And EM could be more optimized by increasing the frequency of EM sessions per day. And the implementation of EM might include modalities such as custom-made walkers for mechanically ventilated patients. We could also recommend the use of resistant bands, tilt tables, and neuromuscular electrical stimulation to further enhance the effect of mobilization among the MICU patients. To conclude, early mobilization process flow included the identification of the safety risk prior to EM implementation for every patient. EM was implemented for every patient within 48 hours of MICU admission. This new EM process flow showed a decreasing pattern of length of stay during the months of its initial implementation. And then finally, the findings suggest that there is benefit of decreasing the length of stay of patients in the MICU when the EM is implemented. And now I open the floor to questions, concerns, suggestions, and clarifications about my project. Please feel free to submit them in the comment section of this video, and I will respond to you as soon as I can. Thank you very much for listening. The following are my references.